Nobody warned Gerald about the clipboard. He was 73 years old, a retired union electrician from Pittsburgh, the kind of man who spent 40 years reading fine print on job contracts, who never signed anything without understanding what he was signing. And the night his wife called 911 because he couldn't catch his breath, the night the paramedics loaded him into an ambulance with fluid building around his heart, within 11 minutes of arriving at that hospital, a woman in scrubs handed him a clipboard and waited while he signed. He was scared. He was short of breath. He signed. 6 weeks later, a bill arrived for $26,000. Not because his care was bad, not because the doctors made mistakes, because of 6 words buried in a document he signed when he was too frightened to read it. I have sat across from patients like Gerald more times than I can count. I have watched financially careful, intelligent adults over 60 lose retirement savings they spent decades building, not to their illness, but to systems they did not know existed inside the hospitals meant to help them. My name is Dr. Pablo. I am a board-certified geriatrician with 18 years of clinical experience working with adults over 60, and today I am going to walk you through 6 hospital traps that are quietly costing seniors thousands of dollars, and in some cases, costing them their recovery. These are not rare edge cases. These happen every single day in hospitals across the United States. The people they happen to are not careless people. They are people who simply did not know what to ask, and nobody inside that building had any financial incentive to tell them. Before I take you through each one, I want you to understand something about the aging body that makes all of this so much more consequential for you than for a 40-year-old patient. By the time you reach your 60s and 70s, your physiological reserve, the body's capacity to absorb disruption and bounce back, has narrowed. Your cardiovascular system is more sensitive to medication changes. Your kidneys clear drugs more slowly. Your autonomic nervous system, the one that regulates blood pressure when you stand up, recovers less efficiently after any kind of physiological stress. What this means practically is that every one of these traps I am about to describe carries a medical consequence for you that it simply does not carry for younger patients. A medication substitution that causes mild dizziness in a 50-year-old can cause a fall and a hip fracture in a 72-year-old. A premature discharge that inconveniences a younger patient can send an older one back into the emergency room within 72 hours. The financial stakes are real. The medical stakes are higher. And trap number 1, the one I am going to save for last, is the one I have watched destroy both at the same time, and I want you carrying that awareness with you through everything else I tell you today. Let's start with trap number 6 because this is the one that surprises people most, and it almost always happens before the patient even realizes they are in danger. You do your homework. You are scheduled for a procedure, maybe a cardiac catheterization, maybe a joint replacement, maybe a colonoscopy with biopsy. You call your Medicare Advantage plan, you confirm the hospital is in network, you feel prepared. Then, 3 weeks after you go home, an envelope arrives from a billing company you have never heard of. Inside it, a charge for $1,400, sometimes more, from a physician you have no memory of meeting. The hospital was in network, but the anesthesiologist who managed your airway during that procedure, the radiologist who read your imaging, the hospitalist who saw you on intake, each of those physicians may carry their own separate network agreements, entirely independent of the hospital that hired them. The building is covered. The doctors inside that building may not be, and the billing comes weeks later, when you are home and recovering, and the last thing you are prepared for is a financial fight. This is called the out-of-network specialist surprise, and for adults on Medicare Advantage plans in particular, it has been a consistent source of financial harm for years. There is a federal law called the No Surprises Act, passed specifically to protect patients from this exact situation, and it gives you a legal right that almost no one exercises because almost no one knows to ask for it. The moment you arrive at any hospital, before any specialist enters your room, before any procedure begins, you have the right to say this directly to the nursing staff or the billing department. I only consent to treatment by in-network providers under the No Surprises Act. That sentence is not aggressive. It is not combative. It is a legal declaration that puts the hospital on notice. If they bring in an out-of-network provider after you have said that, the financial burden shifts back to the facility, not to you. Write those words down before you finish this video. Put them in your phone, because the time to learn them is not when you are lying in a hospital bed at 2 in the morning. Now let's move to trap number 5. And this one does not involve paperwork at all. It involves a conversation that happens when you are most vulnerable, most tired, and most likely to defer to anyone in a white coat. Hospitals operate under enormous financial pressure from insurance companies to move patients out of beds as quickly as possible. What that pressure looks like on the ground, at the bedside level, is a discharge conversation that sometimes happens before a senior is clinically ready for it. A physician comes in, uses language like "you are doing well enough to go home," and because it is a physician saying it, most patients nod and start getting dressed. For a 35-year-old, going home slightly early from a hospital stay is an inconvenience. For a 70-year-old with reduced postural reflexes, compromised renal function, and a cardiovascular system still recalibrating after a procedure or an acute illness, going home before the body has stabilized enough is a genuine medical risk. Falls within 72 hours of discharge, wound complications, decompensation from a heart or lung condition that was still in the process of being corrected, readmission to the emergency room, which costs far more, physiologically and financially, than simply staying those additional days. What most seniors have never been told is that Medicare patients have a legal right to appeal a discharge they believe is premature. That right exists right now. The mechanism is called an expedited appeal through your Beneficiary and Family-Centered Care Quality Improvement Organization, or BFCC-QIO. You find yours at Medicare.gov. Once that appeal is filed, the hospital cannot legally discharge you while the review is being processed. Here is what you say to your care team. I do not feel medically ready for discharge, and I am requesting an expedited appeal through the QIO. Frank was 71, a retired high school football coach from Memphis, Tennessee. He had a cardiac stent placed after a mild heart attack, and on day 2, his cardiologist came by early in the morning, said his numbers looked stable, and mentioned that discharge the following morning was likely. Frank's daughter, who had been sleeping in the chair next to his bed, asked the nurse to connect them with the case manager so they could formally request a QIO review. The attending physician came back that afternoon. Frank stayed 2 additional days. His heart rate, which had been fluctuating overnight in a pattern the night nurses had noted but not yet escalated, was identified as atrial fibrillation during that extended stay. He was started on anticoagulation before discharge. His daughter told me later, if we had gone home that first morning, we would never have caught it in time. Trap number 4 is one that begins before you ever leave your house, and it targets something that for adults over 60 is genuinely life-critical. The medication regimen you have spent months or years carefully building with your own physician. When you are admitted to a hospital, that facility runs its own internal pharmacy off what is called a formulary, a specific approved list of medications the hospital stocks and dispenses. Your maintenance medications, the beta blocker that keeps your heart rate controlled, the ACE inhibitor managing your blood pressure, the anticoagulant preventing clots, may not be on that formulary, so the hospital substitutes a different manufacturer, a different generic, a different dosage formulation, and this substitution may happen without a clear conversation with you, and sometimes without adequate communication to the admitting physician. For the cardiovascular system specifically, this is not a trivial issue. The aging kidney clears medications more slowly, which means even small differences in drug formulation can alter blood levels significantly. A beta blocker substitution can produce blood pressure instability. An anticoagulant switch without proper bridging can increase clot risk. The American Geriatric Society has published extensively on medication reconciliation failures in hospitalized older adults as a primary driver of adverse events and readmission. And on top of the medical risk, the hospital pharmacy bills at premium rates for those substituted drugs. You pay more for something that may not be what your body has been calibrated to. The protection here is entirely within your control, and you can prepare it right now, before you ever need it. Write down every medication you take, the exact brand name, the exact dosage, the exact timing, and the name of the physician who prescribed it. Keep that list on your phone and a printed copy in your wallet. When you or someone you love is admitted, hand that list to the admitting physician and say clearly, "Do not substitute or alter any of my maintenance medications without an explicit clinical review and my written consent." That sentence moves the responsibility where it belongs. It requires the clinical team to flag any substitution before it happens, document it, and communicate it to you directly. This is the halfway point of what I want to walk you through today, And I want to pause here for a moment because I want to hear from you directly. Write your age and where in the world you are watching from in the comments below. I ask because the people watching this video right now are not all in the same place. Some of you are preparing for an upcoming procedure. Some of you are watching because a spouse or a parent is already in a hospital bed tonight. Some of you are watching because something happened 6 months ago that still does not make financial sense, and you are looking for the language to describe what you think was done to you. Whatever brought you here, your comment matters. Someone else watching this right now is in the same situation and has not found the words for it yet. Your story may give them what they need. Trap number 3 is the one that financially blindsides more seniors than almost anything else on this list. And the reason it works so effectively is that it happens in the first 10 minutes of a hospital admission, when you are frightened, when you are in pain, and when someone is standing in front of you waiting for you to hand the clipboard back. Every hospital admission in the United States involves paperwork, consent forms, privacy notices, insurance authorization, and somewhere in that stack, sometimes on its own page, sometimes folded into a longer document with language dense enough that a contract attorney would slow down reading it, there is a clause stating that you assume full financial responsibility for any services not covered by your insurance. Most people sign it. They are not in a position to do otherwise. They are not sitting at a kitchen table with reading glasses and a cup of coffee. They are in a hospital gown. They are worried. And the person holding the clipboard has 11 other patients to get to. So they sign. What that signature can legally do is give the hospital the right to bypass the negotiated rate agreements between your insurance company and the facility and bill you directly at full, undiscounted rates for anything Medicare or your plan does not cover entirely. This is called balance billing. And the difference between the negotiated rate your insurance company would have accepted and the full rate the hospital charges without that negotiation can be thousands of dollars on a single admission. Here is what you do instead, and this is important. You do not refuse to sign. Refusing to sign intake paperwork can complicate your admission and is not the protection I am describing. What you do is write a single sentence directly next to your signature, in pen, before you hand the clipboard back. That sentence is, signing only for authorized insurance benefits, not personal financial liability for uncovered balance billing. You can write it in front of the intake coordinator. It is legal. It documents your intent at the moment of signing, and it protects you from having that signature used against you later in a billing dispute. If anyone in your life is over 60 and has any kind of procedure scheduled, a spouse, a sibling, a parent you are helping manage, take a photograph of that sentence right now and send it to them before you go to sleep tonight. That one sentence has the potential to save thousands of dollars. Now, trap number 2. And this one I have added specifically because in 18 years of working with older adults, I have watched it cause harm that the other traps on this list simply do not reach. Harm that is not financial, but physiological. Harm that happens quietly inside the hospital stay itself and does not announce itself until weeks or months after discharge. It is what I call the diagnostic drift trap, and it works like this. When a senior is admitted to a hospital, the admitting team forms an initial clinical impression very quickly, often within the first few hours. That impression drives the workup. It drives the medications. It drives the discharge planning. The problem is that in adults over 60, the presenting symptoms of serious conditions are frequently atypical. A heart attack in a 75-year-old woman may not look like chest pain and a classic EKG finding. It may look like fatigue and jaw discomfort and nausea. A pulmonary embolism in a 70-year-old man may present as confusion and mild shortness of breath, rather than the dramatic presentation a younger patient might show. A urinary tract infection in an older adult can present primarily as sudden cognitive change, with no urinary symptoms at all. When the initial clinical impression is formed quickly, and the team anchors on it, subtle findings that do not fit that impression can be dismissed or delayed. The Journal of the American Geriatric Society published research showing that atypical disease presentations in older adults contribute significantly to missed or delayed diagnoses during hospitalization, with downstream consequences including longer recovery times, higher readmission rates, and in cardiovascular cases, preventable mortality. What you can do about this requires a specific kind of advocacy, and it requires you or a family member to be comfortable asking a question that some patients worry will seem intrusive. It is not intrusive. It is your right. If you are in a hospital bed and your symptoms are not improving the way the care team seems to expect, or if new symptoms appear that feel significant to you, you or your family member has the right to say to the attending physician, "I want to make sure we have considered all possible diagnoses given my age and the way my symptoms have presented. Is there any atypical presentation we should rule out before moving forward with the current treatment plan?" That question does three things. It signals to the physician that you understand older adults present differently. It creates a documented moment in the chart where the question was asked. And in my clinical experience, it almost always prompts a more thorough review than would have happened otherwise. Carol was 67, a retired pediatric nurse from Albuquerque, New Mexico. She was admitted for what the team initially felt was a gastrointestinal issue, causing her fatigue and loss of appetite. Carol had been a nurse for 31 years. She knew her body, and she knew something was being missed. On day 2, she asked her attending physician directly whether her symptom pattern could represent an atypical cardiac presentation, given her age and her family history. The physician ordered a high-sensitivity troponin panel. Her troponin was elevated. She had been having a slow myocardial infarction, a heart attack, presenting without chest pain, without the classic EKG changes, presenting only as fatigue and appetite loss. She was transferred to the cardiac care unit within 4 hours. Carol told me afterward, "I spent 31 years telling patients to speak up. The one time it really mattered, I almost did not." And now, trap number 1. The one I told you at the beginning of this video I have watched destroy financial security and recovery at the same time. 3 out of every 10 Medicare patients admitted to a hospital each year are placed under something called observation status. That figure comes directly from Centers for Medicare and Medicaid Services data, and it represents hundreds of thousands of seniors annually across this country. Under observation status, a patient is classified as an outpatient, not in the legal or common sense meaning of that word, not someone who walks in, is seen, and goes home, but outpatient on paper, in the billing code, while lying in a hospital bed, while being seen by specialists, while eating hospital meals, while being monitored around the clock by a nursing staff. And Medicare Part A, the coverage that pays for skilled nursing facility rehabilitation and post-acute care after a hospital stay, only activates after a formal inpatient admission of at least 3 consecutive days. Observation status does not count toward that 3-day requirement, not 1 hour of it, which means a senior can spend 5 nights in a hospital under full medical care, be discharged to a rehabilitation facility for recovery, and receive a bill for the entire rehabilitation stay out of pocket, sometimes exceeding $20,000, sometimes $30,000, because on paper, according to Medicare's billing classification, that patient was never formally admitted. Thomas was 68, a retired civil engineer from Sacramento, California. He came into the hospital with shortness of breath and lower extremity swelling, signs of decompensated heart failure. He was in a hospital room for 4 nights. He had a cardiologist. He had a diuresis protocol. He had a care team managing his fluid balance around the clock. He and his wife assumed he was admitted. When he was discharged and his wife called to arrange coverage for the skilled nursing facility where he would continue his cardiac rehabilitation, they were told by the billing department that Thomas had been under observation status for the entirety of his stay and that Medicare Part A did not apply. The rehabilitation bill came to just over $24,000. When I sat with Thomas and his wife, he said something I have never forgotten. He said, "Not one person in that building said those words to me. Observation status. Not one person." If I had known that classification existed, I would have asked them to change it on day 1. Here is what Thomas should have known, and what you now know. The moment you or a family member is placed in a hospital bed, before the first night passes, ask the attending physician or the case manager directly, "Am I admitted as a formal inpatient, or am I under observation status?" If the answer is observation status, say this immediately. "I am requesting that my status be formally reviewed for inpatient admission based on medical necessity." That request must be documented. The care team must respond to it, and in a significant number of cases, when a patient or family member explicitly raises this question, the status is reviewed and reclassified. There is also a federal requirement, under what is called the MOON notice, the Medicare Outpatient Observation Notice, that hospitals must provide written notification of observation status to Medicare patients within 36 hours of placement. If you are in a hospital bed and you have not been handed that notice, ask for it by name. Have I received my moon notice? Those 5 words tell everyone in that room that you know your rights. Now here is what I want you to do tonight, in the next 30 minutes, before this information fades, the way information fades when we do not write it down. Take out your phone or a piece of paper and write down these 6 sentences. First, am I admitted as a formal inpatient or am I under observation status? Second, I am requesting that my status be reviewed for inpatient admission based on medical necessity. Third, I only consent to treatment by in-network providers under the No Surprises Act. Fourth, do not substitute or alter any of my maintenance medications without clinical review and my written consent. Fifth, written next to any financial signature, signing only for authorized insurance benefits, not personal financial liability for uncovered balance billing. And sixth, I want to make sure we have considered all possible diagnoses given my age and the way my symptoms have presented. 6 sentences. That is your hospital protection plan. Save it somewhere, you will find it fast. Share it with the person in your life who would be at your bedside if something happened tonight. Because the most important thing about these sentences is not that you know them, it is that the person who loves you most knows them too. Because there may come a moment when you are not in a position to speak them yourself, and the person holding your hand will need to speak them for you. The adults over 60, I have had the privilege of caring for across 18 years, are not fragile. They are experienced. They are resilient. They have navigated harder things than a hospital billing department. But resilience without information is not protection. You now have both. Use them. If this video gave you something you did not have before, share it with one person tonight, a spouse, a sibling, an adult child managing a parent's care. One share of this video could save someone in your life thousands of dollars and protect a recovery they have been counting on. Subscribe to this channel so that the next video finds you when it goes up. Because what happens after the hospital, the rehabilitation facility traps, the skilled nursing facility billing systems, the discharge planning failures, that is a full conversation on its own, and it follows directly from everything we covered today. I will see you in that video.